So my number one aim this week was to not get sunburn. I didn't want to turn up here as a pasty Brit on Saturday morning with this red head. And I think I've achieved that, right? So my number one aim was achieved straight away. But it's a real pleasure to be here. This has been a fantastic conference so far. There's been some really wonderful speakers. I've really enjoyed listening to some really great science. So what I want to talk about is exercise and movement for pain. That's really my kind of number one subject that I enjoy talking about. And hopefully other people enjoy talking about it too at some points. So my original presentation was going to be called moving away from exercise and towards movement. And the real reason I wanted to talk about this was because of the idea that we sometimes might need to reconceptualize the idea of exercise for some people into the concept of movement. And the real reason we have to do that is because we're dealing with human beings. And one of the big things that I want to do with understanding pain science is start to view things like exercise and movement as things that human beings do, not that ligaments do or tendons do or bits of muscle and gristle. You know, we have to think about the human being. So that was kind of what I was going to talk about before. But my presentation has become a lot broader. And really what I want to look at is exercise through a pain science lens, or exercise and movement through a pain science lens. And some of the things that we are trying to achieve through using movement and exercise. Who thinks movement and exercise is a fairly powerful tool that we can use to help people? Absolutely, it's something people can do to themselves. But sometimes we need to look at the psychology and the social aspects and factors behind movement and exercise rather than, say, the physical or physiological or biological factors. I think they're the most important things. And how often do we talk mostly about those physical and biological and physiological factors? I was reading a Cochrane review recently of exercise for chronic pain. And I was looking in and reading through the methodology, etc. And what I found was that the measures that they were looking at within this review from all these studies for chronic pain were still looking at very, very physical measures. So they looked at strength, they looked at range of movement, they looked at endurance. These were the factors that they were measuring. Now, one of the things that pain science teaches us, it's not all about these physical things. It's about other things as well. It's about things that maybe don't relate to these simple physical factors that go beyond that. And I think that's something that we need to talk about. And when we can talk about it and learn about it and understand about it, maybe we can also do something about it as well. And we can start to reconceptualize our ideas of what movement and exercise do for people. And maybe what we can enhance and change and play around with. Okay, so maybe moving away from some of these physical factors and thinking a little bit more about some of the other factors that we can start to think about. So I kind of scrapped that, right? So this is my favourite measurement, the shit ton, right? So that's 1 shit ton. Now, if I was to say to you 4,582 papers came out last year about chronic pain, you'd all turn around to each other and nod in kind of, yeah, we know, that sounds like a lot. If I was to say 1 shit ton, everyone would turn around and go, yeah, you really know what that means, you know? So, but we have all this wonderful information, you know, dating back to Melzack and Wall and, you know, progressing through and Steve McMahon and all these great pain scientists. And we have all these new ways of conceptualizing and looking at pain. But we still very much see exercise as this very, very physical thing. We're still attempting to change these measures of strength or range of movement, etc. And there's these other things. So Melissa's talk yesterday really resonated with me. So when we look at chronic pain, what brain areas do we see kind of light up and start to be lit up? You know, like the affective, emotional areas of the brain. You know, so if we're going to get people exercising and moving, would fun be a good thing? Would that be one of our major outcome measures? Just getting people moving and having fun, changing people's perception of what it means to move and the emotional attachments that they might have to that. You know, so, but I don't ever see people have that as an outcome measure. Maybe it's, I'm not a scientist, but certainly it's one of these things that clinically I think it would be a wonderful thing that we start to think about, just exercising and moving for the concept of fun. How does that change someone's perception? How does it change their future predictions? We know our brains are these wonderful Bayesian inference machines, and we base our future predictions off our previous experiences. So one of our aims for exercise and movement is to restore someone's enjoyment. How many people who have chronic pain don't enjoy moving? Yeah, it's a real big thing for people. They don't enjoy it. They don't want to go out and do these things. Maybe they're fearful of it. So maybe we need to think about coming away and having a shit ton of information about things that we can do with exercise for pain. So all of these things here we discuss regularly in relation to pain science. So if we're discussing exercise for pain, we should be thinking about these factors as well. And often we don't. If you were to go through NASM guidelines, ACSM guidelines, whatever else other bodies, you would find generally they don't talk about any of these things. You know, our guidelines for exercise aren't directly portable over to therapeutic exercise, in my opinion. We don't know a lot about dosage, but I think this is an area that needs to be explored, the parts of what we talk about and how they relate to people. So we have context. Context is a hugely important big deal. How many people who have chronic pain might not like the context of the gym? Might find it threatening. Might find that that doesn't kind of enhance the therapeutic benefits that they might get from exercising and movement. You know, we have that contextual element straight away. It might be that there are specific contexts, specific movements that people have pain in, and we need to address those, and they are away from what we might traditionally talk about as exercise. What about perception? Someone's perception of what's going on. If we look at modern pain science, perception probably underpins a huge, great big deal of what we're talking about. Pain, you know, is perception, essentially. So how do we think about and alter people's perception, even around the concept of movement? For some people, we may need to take exercise and reconceptualize it as movement and change their perception of what they're doing. You know, so these are things that we might need to address. What about emotion? Again, coming back to Melissa's wonderful presentation yesterday. How do we alter and change people's emotions about what they're doing? They're reinforcing those emotions as well over time, creating that positive context. Really, really important. One of the biggest ones is self-efficacy, one of the biggest things that we can change for people in pain. I think that's one of the biggest things that we can do for people, because how much of treatment can you give people on a weekly basis? You might see them once a week, once every 2 weeks, once every 3 weeks. Empowering people to do things to themselves is one of the biggest things that we can do, I truly believe. And exercise is a wonderful vehicle for that. The exercise vehicle is one that anyone can jump on board. I truly believe that. We just need to create the right environment for them to be able to do it. And that guidance is a really big deal. What about locus of control? Taking someone from an external to an internal locus of control. They can do it. They have the tools to do it. What about education? Education is one of the biggest things, again, that we can do. Educating someone about their role within the rehabilitation process. How many people just want you to fix them? They want you to do something. They want you to take their pain away. It's mostly, for me, about educating people about their role within the therapy or the rehab process. Where do they fit in? And then finally, reconceptualizing. How do we reconceptualize some of these concepts for them? So these are all things. Do you recognize all these words from pain science discussions? How often do we think about those things in response to exercise? Not so much, right? So I think we need to have a look at how we can kind of cross those boundaries. I think that's a really big deal. What are our aims of moving? I think that's one of the first things that we have to ask ourselves when we get people to do stuff. What are our aims of moving and exercising? Because Facebook told me exercise is good. Because we have these wonderful online discussions where we argue about what's the best thing to do. And some people say, do this, do that. So that, you know, that's a fairly scientific reason. Fairly. Do we want to increase someone's load tolerance? Potentially. That might be a very traditional aim of exercise. Lots of exercise is about loading, and that's an excellent thing. Changing things like basic tissue tolerance. Improving someone's aerobic capacity. We know that these things can have an analgesic effect on pain. Activating a muscle. or sometimes deactivating a muscle. You know, when we talk about things like lower back pain, we know it's not always about switching things on. Sometimes it's about switching things off, right? So we need to think about that as well. What about increasing someone's strength? That's often an aim, a traditional aim of exercise, and potentially increase their work and rate of perceived exertion. Maybe, though, we need to have some different aims, some newer aims. What about creating new positive memories? So if we look at the work of Herta Flor, if we look at the work of Max Zussman, if we look at the work of Joe Nez, you know, very much taking these previous pain memories that are negative, how can we alter and change those? Do I need to measure physical measures? Do I need to measure these objective physical measures? I don't think I do. You know, potentially other people may want to, but I'm much more interested in these subjective measures of how moving makes you feel, how it makes you want to move more in the future. They're much more important to me. What about freedom of movement? How many people don't have freedom of movement? Exercise traditionally is actually about rules. What differentiates one exercise from another? Instructions and rules. Do people who have pain or chronic pain, do they have too many rules sometimes? Do they have behaviours and beliefs that create rules? And sometimes we need to take those away. Sometimes we need to reframe these things for them. What about just having thoughtless movement? If you were fear avoidant, would just being thoughtless and fearless in what you do, and I'm quoting the great Louis Gifford there, would that be a big aim, a kind of a subjective aim that we could think about? Just having basic flow. You know, these are kind of words that we don't think about when we're exercising and moving. You know, they're kind of more to do with maybe, you know, kind of therapeutic processes, but I think they're very, very important. If we're going to take those concepts and match them to each other, we need to think about how we're going to do that. And as I've kind of alluded to already, enjoyment, just basic enjoyment. How can we get people to enjoy just moving and enjoying their bodies again? And it may be that no physical measures ever change, but I can change that one thing, and that may change everything for that person. Okay? Maybe we need to start to make it meaningful and relevant. And listening to Professor O'Sullivan, you know, I could tell that's where he was going and thinking about as well, making it meaningful and relevant to the person. Why am I doing this? What does it really mean to me? If you think something's irrelevant to you, are you likely to do it? Probably not. So again, you know, it might be that the thing I get you to do is the most evidence-based thing. It's been studied to death. But if it doesn't resonate with me, it might just not get done. It becomes irrelevant. Okay, so thinking about the why behind the what, I think is really, really important. Sometimes it might be moving mindfully. And we have lots of wonderful mindful movement processes that I think are very, very beneficial for people. And finally, we may just help kind of desensitize. But it sounds like I'm very biased about movement, and I am exceptionally biased about movement. I think it's a really, really wonderful thing. And I don't think it's a bad thing to be biased about, right? I think it's a really positive thing. But exercise is not the answer. It's not simply the answer. So this is the neuromatrix model from Melzack. And really what that tells me, in really, really simple terms, is it's complex. It's really complex. And there's multiple things going on. And one of the things that I see with lots of exercise studies, we do all these exercise comparison studies, and we'll take exercise X and we'll put it against exercise Y, and we'll say, well, there's no difference, or there is difference, or there is, you know, there's a million different answers. But often, I test two exercises. You know, I don't test them, clever people test them. You'll test two exercises and, you know, they'll kind of come out the same. And people seem to think exercise now is a magic bullet. It doesn't matter, just get them exercising. And I don't think that's true at all. I don't think that's true. Just any old exercise won't work for people. I think we have to be more reasoned than that. And what this model tells me, and there's the famous quote by the statistician George Box, which is, all models are wrong. Essentially, all models are wrong, but some are useful, right? And where this model is wonderfully useful, and what it tells me most, is that no singular intervention is going to provide the answer for complex things. And human beings are really, really complex. So it may be that people need pain science education. They need manual therapy. They need exercise, and they may need them in different ratios. But I think we often get driven into these camps where we say, this is best, that's best. And actually understanding the complexity of people, understanding some of the wonderful models that we have, allows us to understand that multiple things will affect people on multiple levels. And that's what pain science teaches me. So I'm thinking if we look at exercise through a pain science lens, we have to start to understand there are many factors occurring that we can start to kind of look at and think about. So this is the Cochrane review that we were talking about before. And we see some really positive stuff. So we see reduction in pain severity and improved physical function. That's a good thing, right? I'll take that. That's a good thing. But we only see small to moderate effect sizes. You know, we don't see these huge effect sizes. And we see small sample sizes and potentially underpowered studies. Cochrane reviews always say they're underpowered because they want really big studies. They're very harsh, aren't they? They're very harsh. But the question I have for people is why do we expect to see large effect sizes from a singular intervention? You know, and there's some really great studies that are starting to come out now that are starting to combine interventions. There was a great one that they did for laboratory workers in Denmark, I think. And they looked at some strength measures, and they looked at some motor control measures, and they looked at some cognition, and they looked at some mindfulness, and they brought it all together. You know, and I think that's really important to understand that exercise is fantastic. I really enjoy it. Well, sometimes I enjoy it, it depends. Like everyone else, you know. And sometimes we need to reconceptualize for people that actually you do need to do some hard work sometimes. But why should we expect to see these large effect sizes out of a singular intervention? We should all be open to each other to say that manual therapy can have an effect, pain education can have an effect, you know, movement can have an effect, rather than kind of going into these small camps where we expect our intervention to be the best. I think that's a really important thing to understand. It's the same when we review pain science information, pain education stuff. We see small effect sizes. And it doesn't surprise me. I don't think, oh my God, it's not worth doing. I just think if I integrate it with other things, hopefully it addresses some of this complexity. But still, exercise is pretty good, right? It really is pretty good. So exercise for general health is a really important thing. And that's something that we need to have the science and the data for to be able to help inform people of that. Okay, so exercise simply is associated with lower levels of pain. There was the wonderful study a couple of years ago where they found that activity promoted anti-inflammatory macrophages and inactivity promoted inflammatory macrophages. So we see that there are physical kind of changes that occur, biological, physiological stuff going on. We see crosstalk between tissues during exercise, protecting against things like cancer. I think that's a big deal. I think that's a big deal. Retinal failure and metabolic disease. So understanding and helping people understand general exercise is absolutely, you know, vital for them is great. But also addressing some of the things that maybe are important to them is also fantastic. Sometimes we can be more specific, sometimes we can be more general. Who defines that? The person standing in front of me, right? Not a research study. Again, we have to be informed that we can have these benefits, but also be able to drill that down to the person standing in front of me. So we actually have no concrete idea on how exercise works for pain at the moment. So we might have ideas about specific effects, and we might have ideas about non-specific effects. And I think that's important to understand. We don't really know how it works, because there could be lots of things that we measure that change that don't always relate. One of my favourite studies is a study they did into lower back pain. Well, it was a systematic review, so they pulled lots of papers together. And what they wanted to find out was if getting better using exercise from lower back pain was tied into any physical measures. So if you target a physical measure such as strength or range of movement or endurance or stability, if that had to change for someone to get better. That's what they wanted to target. They wanted to find out from all these papers that they included, did this thing have to change? And guess what? They didn't find any correlation at all. So these physical measures that we target don't have to change for people to get better using exercise. So the question is, what did change? And if we can ask that question, how can we start to emphasize some of these things? Could it be local physiology? Could it just be bathing irritated receptors in blood? Who knows, bringing wonderful oxygen in there. Could it be that we're sending messages up to the cortex, refreshing the homunculus and affecting things in that way? Potentially. Could it just be that we are changing a lot of these factors that we discussed before? Someone now feels like they can move. They're happy to move. They're changing how they feel and how they perceive what is occurring to them right now. Okay? So it's really important. These findings are replicated across studies. So range of movement. They looked at hip range of movement for patellofemoral pain. So people with patellofemoral pain had less range of movement at the hip. After they got better from patellofemoral pain, they still had less range of movement at the hip. Okay? So, I was taught to do joints above, joints below, active, passive, and find what was going on, right? I'm sure that echoes a lot of everyone's education. You find these measures, and what is the idea? What do we want to do to these measures? We want to fix them or change them. Do we have to do that? Are these the things that we have to focus on? I don't know. Same is true of shoulder kinematics, shoulder posture. There's been lots of studies on this. We target shoulder posture. We target kinematics. Do they have to change for someone to get better? Absolutely not. At the end, and what they do with these studies that aim to change them is they put that right at the very end so that you hopefully you don't really read over that bit, So it's important we understand that these physical measures don't always have to change. But let's not throw the baby out, because you can see baby doesn't like it. All right? Baby doesn't like it. Really doesn't. In fact, every time I see that, it kind of hurts me emotionally, but that's fine. Right? So there's definitely a continuum between the physical and the physiological, and also the simple and the complex, right? So sometimes things are very simple. Sometimes things are very physically based. If I take someone who's elderly, could basic strength training have a huge effect on their life? It may not need to be complex in any way, shape or form. But we may need to take another scenario where it's not so physically driven. It's much more psychologically driven, and we have to start to think about that, and we have to start to understand that a little bit. Okay, so let's not throw the baby out, and that's not what I'm saying. I'm saying let's look beyond potentially what we already have and expand on that and build on that. And actually, helping people have fun moving is really fun, right? When you change people's perceptions of what they're doing to themselves, that makes me feel good. It does, and I enjoy my job. It's much better than some of the hard grind that you have to do sometimes. Having fun and enjoying stuff with people, it's a two-way street. It's a reciprocal thing, hopefully. All right? So, always remember the effects of exercise are psychological within themselves, in part. And they've done a few studies on this. So if you believe exercise will work, it probably will to some degree. They did a study last year about expectations affecting psychological and neurophysiological benefits. They did another fantastic study where they took maids in a hotel and they reconceptualized their work as exercise. And guess what? Heart rates went down, blood pressure went down, work rate didn't change. They did exactly the same thing on a daily basis, but they got more benefit from it because they perceived it differently. So again, we need to change our ideas. But what is one of the biggest measures that we have today in therapy about what's going to successfully predict outcome? Does anyone know? Yeah, well, it's actually whether someone expects to get better or not. So it's predicted expectation. There was a great paper by Chester last year looking at the shoulder. And they looked at all these factors. The number one predictive factor for getting better from shoulder pain was if you expected to get better. Why? Why do we think that that might be a factor? Because people actually do the physical thing, right? If you don't do the physical thing, then it actually doesn't matter. So there's been lots of papers on these things, but we need to understand what people's expectations and perceptions are of what you are doing with them. That is my number one goal often, just to find out what someone else thinks about the thing that I'm going to give them to do. Doesn't matter how evidence-based it is. The best evidence-based thing in the world, again, becomes redundant if it doesn't get done. Doesn't mean you shouldn't use it, but it means that we need to fit it in with the person and maybe conceptualize it in different ways. Okay, I think that's really, really important. Think about this. If you come to see your physio or your therapist or whoever, and you've had a terrible, bad experience previously with exercise, does that affect what's going to happen in the future? Absolutely. Have people failed with using exercise in the past? How many people in here have made it a New Year's resolution? How many people in here have broken it? So is the same thing true of exercise? So is exercise always, someone's perceived best vehicle for treatment? How many people, again, want you just to come in and do something to them? So, as I said, this could be failed physiotherapy, but it also might be failed exercise in general that could influence my future perceptions of what exercise means. And we also have to be careful about bias with exercise. We have to be careful about bias because often we think the thing that works for us is going to work for them. If I'm into strength training, are there psychological benefits to be derived from any type of training? Absolutely. But that is in the eye of the beholder. How does it relate to the person? It's not just about you could get non-specific benefits from this. It's not that you will. You could get, and it would depend on the bias of the person standing in front of me. So we have to think about those things as well. I had to get him in. One of my friends tried to get me to get Anchorman in, but I'd already got Fat Bastard in, so I didn't know if you guys could handle that. One of the big problems that we have, and I find him sexy, but I'm deeply disturbed, it's fine. So one of the biggest challenges that I think we have moving forward is helping people engage with what we're getting them to do, okay? But it's not sexy. It's not a sexy subject, unfortunately. I see people argue about the what all the time. What's the best thing? Loading it, doing this, move it. We have all these different camps of type of exercise stuff. But actually, the reason why and how someone is going to do it isn't a sexy subject. It really isn't a sexy subject, but it might be the thing that gets people better if we help people and empower people to be able to do it. So, if you find him sexy, you can meet me after. We won't go there. But it's not a sexy side. I just want to find someone else with that kind of fetish. It's taken me years. It's not a sexy subject, but I think we should make it sexier. And again, it's not the bio, it's the psychosocial part. And the psychosocial part might actually have the biggest effect on the bio, not the bio itself. Okay, just reconceptualizing it, that kind of concept. So what can we do? What can we do about it? Firstly, I think we need to change our ideas about goal setting and how we get into and doing goal setting and how we really get out of people what they want to achieve. I think goal setting is one of the biggest things that we don't work hard enough on. And I'm generalising. I'm sure some of you do wonderful goal setting, okay? Things that people really care about. And what does all this stuff come from? Interaction, from listening, from communicating, from creating that therapeutic alliance. So what do people really care about? What are we measuring? Outcome measures. We have to have outcome measures. In the UK, outcome measures are slightly different from over here, I know that. But things like the patient-specific functional scale, measuring what is important to them. What are these outcomes? Are we exploring exercise preferences and enjoyable activities? I think these things are just, they're the magic bullets. Finding out what they like. Finding out about people's previous experiences, both positive and negative. Can we build on the positive? Can we address the negative? But to do that, do we have to understand it first? I think that's where we're going. One of my pet subjects at the moment is what are the barriers to people exercising? Okay? One of my pet subjects, and there's not a ton of research, but there is some quite good research out there. So what are the barriers to people exercising? Because if we don't know them, how can we address with them? How can we deal with them? So what do you think the number one barrier is? Pain. Making pain worse. Why people don't want to exercise. Is that completely logical? Absolutely, it's completely logical that people don't want to make pain worse. So what can we do about it? This was from a paper in 2010, Barriers to Treatment Adherence in Physiotherapy. Okay, so it quite nicely fits the bill, really. I like it when that happens. So making it worse. What are the things that we can think about? Dosage. How can we use dosage? That's one of the biggest things that we don't know about with therapeutic exercise. As I said before, exercise is not therapeutic exercise. They are not one and the same thing. So we need to think about dosage. We need to think about the stresses people are under already. We need to think about irritability and these kind of things. Because the number one thing that I don't want someone to go away and do is react badly. I want to minimise that. I want to create the minimal effective dose. I want to bring that down. So how do I do that? Well, we need to look at the person, look at these kind of, when I was taught manual therapy, we looked at the SIN with Maitland and stuff like that. And can we do things like that? I think that's very important. Maybe we can add in what's happening in people's lives as well. Education. Educating people potentially about what happens if it does go wrong. And we don't do that a lot. We don't educate people about what sensations in their body might mean and what to do if it all goes wrong. So could you perceive normal muscular soreness as very negative in a part of your body that you don't have great associations with? Normal muscular soreness, you might, if you go to the gym, how do you associate muscular soreness if you're a weightlifter? Oh, it's brilliant. Oh, I've had a great workout. How might you perceive it if you've never felt it before and you've had a previous history? What does it mean to you? Am I going to be able to go to work this week? When's it going to go? Is it going to trigger the problem that I had before? So we need to think about one of these things. One of my favourite analogies is just sunburn. So what do we do if we get sunburn? We change the dosage, right? If I get sunburnt, do I stay out of the sun the next day? That's what I do. I simply just stay out of the sun. Am I more careful when I go back in the sun? It's, these things, helping people to conceptualise that it's not a problem. It might just be a dosing error. And what I can do is I can change that. I can change the dosing. It's really, really simple stuff. Could I be genetically predisposed to being overloaded? If you have pale skin, if you have red hair, these things are things that affect your loading, in terms of the sun and probably with exercise too. What if you haven't been on holiday for 2 years? I know, Americans moan about not getting enough holiday and that kind of stuff. Yada, yada, yada. But if you haven't been on holiday for 2 years, are you likely to be underdosed? If you haven't exercised for a long time, are you likely to be underdosed? Does that affect your dosage? It has to. It's not just about an exercise dosing. And finally, we need to give people this information about how they can alter their dosage. What do I do if it goes wrong? Do I take the reps up, sets up, time up, weight down? This is about creating self-efficacy with people. It's not what you do, it's about giving them the tools to do it for themselves, okay, and addressing these things. So pain, we might look at dosage. We might look at education. We might look at self-management. But there was some other stuff in here as well. So there were some other things here in these barriers. So low self-efficacy. That is a barrier to exercise adherence. And maybe we even want to change the idea of what adherence is. Maybe we could reframe it as commitment. Adherence, I don't think that's a great word. It doesn't trip off the tongue very nice. It's quite, forceful. Maybe we can frame it as commitment. So asking someone, how confident do you think you will be at doing the exercises or sticking to the program? How confident will you be? Planning. The biggest thing that I ever do with people is just planning. Is working out how they are going to help themselves. I don't spend hours on, going over exercise technique particularly. I'm not sure how much exercise technique matters, potentially sometimes. I know that I have given people exercises to do, and they've come back and shown me what I gave them to do, and those two things did not look the same. But sometimes they still get, and a lot of the time they still get a really positive benefit out of it. And I know that everyone will have had those experiences. You do not get a verbatim copy back. And you're like, well, did we do this together? So really important, helping people build confidence. So people who envisage barriers, addressing the people who envisage these barriers. What might barriers be? Time, family, work commitment. Where does it fit into their lives? Again, it's about the how and the why, not the what. That's the message that I really want to reinforce, okay? What we have to do is start to plan to overcome these barriers. Some people might see that it just won't help. It hasn't helped in the past, so why would it help in the future? Well, that's the thing that we've got to address. How might it help in the future? So, current low levels of exercise or failed exercising. What do we need to do? Find out current activity levels. Find out what people currently are doing. Does that fit in with our ideas of dosage? If someone has a current activity level, you know, how do we process that? Well, we need to process that and we need to turn that into an output. And that output is directly related to the dosage that we give them. These are the signs and the signifiers. Why have they previously failed? You know, we need to dig into that. And one of the things we really need to do is set realistic levels for treatment. Something realistic for that person. Small, achievable goals. Activate the reward system. Get some of that dopamine flowing around the brain. I think it comes from the nucleus accumbens, but I'm in a room of people who know loads of stuff about the brain. So I'm going to... You can correct me later. Yeah, how can we get these small, achievable goals going? Activate these reward systems and make people, you know, happier. I'm sure that dopamine stuff makes you happy as well. I think so, and I've heard it does anyway. What are some of these other things? Low levels of support. You know, that could be from family. And I know that Peter O'Sullivan was talking about that. Going and communicating these things to your family. How can they provide you support? What about you providing people support? I always say, if you have a problem, if you have a question, what are you going to do? You're going to email me. And I'm just going to reply. It doesn't matter. I'm fine. Email me. If I'm busy, if I'm in like Saint-Tropez sunning myself, I can still reply. So giving that support. And then thinking about anxiety and depression as well. Okay? Because anxiety and depression has this big effect. So can exercise be helpful for depression? Some studies have shown yes, some studies have shown no, so that kind of leaves me at a bit of a maybe. But you can try, right? But certainly having a decent referral network on as well to people who can deal with other issues as well. So there's more factors. I know you were thinking, you know, shut up, it's fine. There were predictive factors. I know, who is this English guy? Where did he come from? There are these predictive factors as well. So they did this on an odds ratio. The number one thing that stopped people from exercising and doing their home exercise program for neck and back pain was, does exercise fit their daily routine? How do we deal with that? Communication. When do you think you will be able to do it? Where do you think it will fit into your lives? You know, because if someone doesn't think it will fit in, they just won't do it. That's the long and the short of it. If someone has any inkling of doubt about something, that is a barrier to doing something, right? It's like going onto the internet and paying for something. Unless you can do it really simply, people won't do it, right? You know, that's why they set websites up in the way that they do. So exercise fitting the daily routine, that's something that we need to discuss. Positive emotional support, again. What I really like is across the two studies, we see some really nice crossover. You know, which is always good. It shows that we are starting to understand a little bit more about the human being exercising, which is really what I'm trying to discuss here. So, positive emotional support. Does exercise fit the daily routine? That people not having enough time. Again, these two things interact. Fitting the daily routine, having enough time. How many exercises are you giving people? Again, in this study, if you gave people over 6 exercises, that was an instant fail. Again, how many exercises are we giving people to do? 1, 2, probably the optimal number. I think there was a study that looked and found that it was 1. So self-efficacy, again, that's another factor that's coming up, okay? And then previous participation and adherence. What did I say the brain works as? A Bayesian inference machine. It predicts the future based on the past. Okay, so previous failures can predict future failures too. Okay, it reduces self-efficacy straight off the bat. But more interestingly, let's look at the things that we can do as well. Let's look at the physiotherapy behaviours, or let's generalise that to therapist behaviours, because I don't think it's going to change that much whoever's giving that information, right? Clarifying doubts and questions. I was taught to give people sheets of photocopied exercises. Does that, yeah, how many doubts would that give you? Who's ever been and got a gym program where they take you around and take you on the machines? And then you get to the end and think, what just happened? You know, we don't learn like that, right? You get to the end and think, am I meant to do this again on my own? So clarifying doubts and questions straight off the bat is so important. Supervising exercises in the health centre. Taking some time to tell people what to do. Is that a good opportunity to clarify doubts, clarify questions? Absolutely, it's input. Asking about adherence at home, accountability. There's a lot of parallels between weight loss, I think, and exercise adherence programs. How we create accountability, how we create structure, and all these different things. So again, creating some element of accountability. I often don't ask people about their pain. I ask them what they've been doing, what they've been, you know, how they've done their exercises, etc. Have you had any problems doing your exercises? You know, have you managed to do them? I don't really touch that much on the pain aspect. And then justifying the usefulness of an exercise. If I don't think that exercise is going to work for me and it has no relation to me, again, you know, I'm being a bit repetitive, but I think they're repetitive messages. Justifying the usefulness of the exercise is a really, really important thing. Why will it work? How will it work? You know, if I know that, I have some kind of commitment and I have some, you know, something in there with that, okay? So, what are our take-homes? Number one, the person exercising really, really matters. Okay, not the exercise, it's the person doing it. I think that's my number one take home from all this. And I could have saved you loads of time, you could have just gone for coffee, and we could have just did one slide, but, you know. I also wanted to talk in my wonderful English accent, so it's fine. So I'm playing on it. I can't get away with this at home, right? I have to play on this here. I'm working it, right? So people need to know why they're doing something. They really need to know why they're doing something. You know, to be invested in it, to think that it's there for them, okay? And again, this is what pain science teaches me, and this is what pain science kind of points me in the direction of, is that just thinking about that human being. They need to know how to do it, and how does it fit into their lives. Okay, they need to know how to do it, how does it fit into their lives. I think they're really important, okay? Human beings need support. Have you noticed that? Right? Human beings really need this support thing. It really works. You know, that's why we form these little family units and stuff. So we need to be able to support people, and we need them to feel comfortable to clarify their doubts and ask their questions. Okay? Find out about potential barriers. Because if you know about them, you can do something about them. How do we do that? We communicate. We communicate. We don't just give sheets of exercises. We don't photocopied so that they're so grainy you can't tell a deadlift from a bicep curl, right? You know, that thing's been photocopied so many times, and then you've lost it and photocopied it again, right? So we need to find out about those potential barriers. We need to educate and plan to address efficacy. Okay? So we need to educate people about how to make themselves better at doing what they need to do. Because the time that they don't spend with you is much more than the time that they do spend with you. And some of that time they do spend with you should relate to a hell of a lot of the time they don't spend with you. And that's quite a simple equation, right? Time in and time out. Okay? And always remember the effects of exercise are much more than simply physical. There are non-specific effects that go across the entire realm of therapy. Why would that be any different from exercise? And if we know that, what can we do about it? How can we improve those factors? And again, it comes back to understanding the basic human being behind and their enjoyment, their preferences, their desires, their outcomes. Thank you. Thank you.
All right, we've got time to take some questions, and we've got a question actually up here in the front row, so we'll need a microphone right up here. I had thought about trying to have you and Roderick arm wrestle, but I think he'd kill you.
No, I only cuddle. I'm an Englishman.
Hi, Ben. Thank you. That was excellent.
Thank you.
I have a question for you about exercise modalities like CrossFit and the higher intensity work that we often see trying to get patients from a pain level, from pain to a performance level. And some of the ways that might be effective to talk to them about when they're engaged in very sort of dogmatic, normative exercise programs like CrossFit that says you can only do this in one specific way, and when those ways tend to flare up patients. So I'm looking for practical solutions.
Yeah, well, I think, again, it comes down to not the exercise itself, but how people perceive it. You know, and how you can educate people on... I always tell people to do these things in a way that they can do it. So that they need to learn how to sit out certain portions. They need to learn out things that flare them up.
What about talking to coaches?
That you mean on a professional level?
On a professional
I see,
level.
not patients. Well, that's more difficult, right? And I can see why you asked that question. Yeah, I mean, I always think we can say to coaches and professionals that not everyone is the same. You know, they don't have the same level of robustness. You know, they don't have the same previous experiences and injury histories. And that maybe if, you know, I would say, do you care about these people? You know, that we have to bring in that emotional side and say, this person isn't ready right now to do what you want to do. How do we make CrossFit work for them? How can we collaborate to actually make this the best for them? And, you know, this is the thing about these coaches, sometimes that they need to take ownership of the people that are the weakest. And they need to help them and progress them and nurture them, rather than teach, you know, a homogenous flock, if you like. But I think it has to boil down to communication, doesn't it? And part of the problem with communication is it's obviously often this, you know, that we have to think there are two people communicating beyond the information, and that we need to think about how the other person perceives us and our professional specialities, etc. And I think the best way to always go about these things is humbly. That probably doesn't answer your question, but that doesn't matter.
We have a question from the internet.
The interweb.
From, yes, one of our online participants.
There's two questions. This first one is from Tess Husted, and she asks, what types of movement have you found in your clients that have provided the most enjoyment, parentheses, fun, close parentheses?
I think on a generic level, that's really, really difficult to answer. Because if we think about one person likes swimming, one person likes tennis, one person likes golf, other people like pool, you know, which I'd probably steer away from to get people active. It's not great. But, you know, I think the whole point of what I've tried to say is that we need to move away from thinking about the thing. What is the thing? The thing changes. The thing evolves. It depends on who's doing the thing. You know, so what they enjoy, simply what they enjoy the most. So I just say, you know, what type of exercise do you enjoy? I mean, it's not rocket surgery. It really isn't.
Good.
I like the way everyone was just thinking about that one. Yeah.
Surgery
better that way.
via
You like
rocket
it?
sounds painful. The second question is from Katie Schotmeyer. How do you educate people who crave high-intensity exercise but continue to put themselves into pain flares by trying to go back to that type of movement?
Yeah, I mean, do you know what? I think the whole point is we need to find out the drivers behind it. Do you see what I mean? It's about understanding why people crave. So if you take something like CrossFit, for example, there's lots of social aspects that fit into the world of CrossFit. So when people get injured or have pain, they also lose some of their social life as well. Is the same true of the running club, the tennis club? You know, so actually sometimes it's the social factors around the thing itself that are most important. So I want to find out why this person wants to go back or needs to go back so much. What is it in there that we can discuss? You know, how can we understand, again, the why behind the what? I think that's the most important thing, is to look back and then start to say to people, you know, maybe there are some other factors that you can get from it and still participate without getting the kind of the thing that you go for sometimes. Not everyone realises they go for some of the social factors as well. You know, it's about the exercise, but it becomes so much more than that. It becomes people's lives. And I had a woman a number of years ago who had moved from a different part of the country, and she was, you know, she'd found a local box. And when she actually burst into tears when I said, you're going to have to like leave this alone for a little bit, because they were her only friends. You know, it was somewhere where she had gone to get this social contact. Her husband had moved. And, you know, she had very I think it was problematic for her that she didn't have social support, and she found it through the medium of exercise and specifically CrossFit. And is that brilliant? If we can get people moving like that, that's wonderful. Sometimes we have to work out some ways that we can take these generic things and make them slightly more individual. You know, but that's not a generic answer, if that makes sense. We need to do the digging. We need to find out why.
So the impression I'm getting from some of what you're saying is that when we're looking for a recommendation for somebody to have exercise as a portion of their recovery, that, you know, in a way it's like everybody has their own favorite toy. And so you're not telling them, here's the toy you're going to play with. You're kind of trying to figure out like what their favorite toy is, and then how can you safely use it.
Because people aren't always going to tell you, you know, I've got Roland Rat or Winnie the Pooh. You know, you need to find out that information. What's your favourite toy, Jason? That's the big question that everyone wants to know, don't they?
Shh, Kelly. Shh.
Oh, we've got insider information, yeah.
Yeah, you can talk to her on break.
Yeah, we will do. We'll talk. Me and you talk. I'll see you.
So one of the things that I was kind of struck by in the class that you did the other day too, was you were taking people into different types of positions to have them explore different kind of movements. And I was wondering if you could speak a little bit to the process behind taking somebody from, say, a sitting position or a standing position into whether it's an all fours or something like that. Like, why would you, like how do you use movement when you've got somebody that's in a great deal of pain?
Yeah, so for me, often it's about finding different ways to move when someone's in pain. You know, and the thing about the motor system and pain is they have a relationship. You know, we often see changes in stiffness, we see changes in variability, etc. You know, that's how the motor system minimises kind of threat and danger. So for me, it's about creating movement exploration in the most safe way. So finding a position that someone feels safe to move in a very low-level way that's going to have a kind of the minimal effective dose, right? How do I create the minimal effective dose for this person to help them understand that movement is safe again, that input is something that can be tolerated? I think that's kind of mostly what I'm looking for with that kind of thing.
How can you tell that was an effective dose?
Well, it's very, very difficult. So actually, I find that mostly you can do that on two levels. Sometimes that happens instantaneously. Someone will say it hurt, or it feels different, or it burns, or all these other expressions of pain that people have. The trickiest thing about dosing is that sometimes it has that 24-hour pattern. And one of the reasons I'm looking for a minimal effective dose is because I don't know what's going to happen in 24 hours. Who knows that line in the sand, right? We never know that. When we give someone a dosage of something, we never know that line in the sand. So we have to think about how can we kind of give that minimal effective dose in terms of volume, in terms of intensity, in terms of position, in terms of variation, and that kind of thing. Really, I suppose what I'm thinking about is kind of a clinical reasoning for exercise and movement. Rather than it being plug and play, fire and forget, we're trying to think a little bit more about what are the potential side effects that could occur, when they could occur, and how potentially I could minimize those.
When we have a number of people here that, you know, obviously they're physical therapists, and so movement is part and parcel of the work that they typically do. Okay, but we have a lot of folks that are also both here and online that are, you know, from the worlds of massage therapy and rolfing and structural integration and other forms of body work where movement is not necessarily part of what they do. And I was wondering if you, like, what takeaways would you give those who are not currently qualified to be having clients moving around in their office? Like, what recommendations would you give them as far as what to say to their clients that ask them about movement?
Well, I think you have to look at movement in a much more general sense from that perspective. You know, it's not about symptom modification per se. You know, maybe you do that in a more manual sense. It's much more, again, potentially about finding out what people enjoy, you know, and just being advocates of movement and exercise. That's really, I think, the best way to view it, is be an advocate of movement and exercise, you know, but potentially, you know, not in a very specific sense, but maybe in a much more general sense. Can you ask the question, what do you enjoy? Absolutely. Can you ask the question, what seems to aggravate the problem? You know, and if you can cover those two bases, then you can work out something to do in the middle that fits those two aspects. I think you're going to be winning. Well, I hope you're going to be winning anyway. But you might also want to say, we need to think about those things. So what if someone said, I enjoy Zumba, or I enjoy some form of like dancing class? You can tell I don't do a lot of dancing classes, right? What would I need to think about? Could they tolerate doing that dancing for an hour? It might be beneficial in a smaller dose. How can I get someone to do a smaller portion of the class? Do they do a shorter class? You know, sometimes with sports, it's very difficult to get people. I had a guy that I was struggling to get back from playing one set of tennis to two sets of tennis, because they're in a very defined set. Really, I needed to play one set of tennis in a game, 2 games, 3 games, and build it up like that. But from a kind of competitive sense or a kind of game sense, the constraints of the game, that's very, very difficult.
We have a question over here by the left pillar.
Hi. So I am a massage therapist as well as teaching dance fitness and Pilates. And I just wondered if you ran into this problem before. I have some of my male clientele, we do certain stretches for movement, movements for pain. And they do exercise, but they like want to do a specific thing because socially I think they feel like that's what they do because this is how men work out.
Like this and
you know,
like that.
And I'm like, you should really try this yoga class or come to, you know, my Pilates class. And I don't know if, I just wanted to ask if that's something that you run into as well and how you kind of would encourage them to try something like that, that you know that would work well for them, but they might not see as fitting to their lifestyle.
Yeah, sometimes I think we need to think about working out, and sometimes I think we need to think about working in. And that some of your workouts are working out, and then other times we can work in, and that's fine. You know, even the best athletes have recovery stuff, right?
Yeah.
So, you know, frame some things as recovery-based and frame some things as really working out. I know that Nick talks about vitamins, that different exercises give us different vitamins, like a balanced diet, and that we need to view exercise and movement like that.
We've got time for just one more question from the Melissa Farmer.
Hi.
Hi.
Thank you for the fantastic presentation. Something I've noticed in a lot of chronic pain patients is that the reward is removal of various levels of pain, but the reward is just sort of the reward of neutrality, such that many times whenever a patient is moving, or even whenever they they have a treatment, the reward or the effect is less pain, but it's still pain.
Right.
So a lot of the, ways that someone could move that's fun, it's still all painful, but maybe less painful. So how do you reframe less pain as a reward that someone would want to sort of work to?
Well, I think potentially, I knew she was going to ask a difficult question, I could just tell. The last one's always the most difficult, right? Well, I still think that less pain is still less pain. So that in itself, and again, I think this is probably where we have to agree on what is a good thing. Would most people in chronic pain accept a little less pain? So I mean, potentially that would be so. What does recovery mean is a really big thing. So for some people, pain is actually okay if they can do some of the things that they want to do. So if I can so it's agreeing what recovery means sometimes. So there was a great paper on that last year, quantifying what does recovery mean anyway. So potentially it might be if I can get someone functioning in something that they really enjoy, like doing their shoelaces up or something like that. Because some people, if you can't do it, that is a really big barrier to the quality of your life. Would you accept a little less pain to do that? Potentially. Some might not. Some might see the complete cessation of pain as the only result that they're going to get. So again, it has to be kind of an individual thing, but that's why we have outcome measures. That probably didn't answer your question, but I knew you were going to answer complex one anyway.
All right, let's give a big La Jolla clap.
Thank you.